And okay, recording in progress now. So we have a tight agenda, finishing sharp at 12:45 p.m, so we'll get on straight away. I'm Sarah Roberts and I'm chair of the CIPR Health Group, and I'm joined by my co-host Kat Raven, who is also taking part in the event today. Our conversation is going to centre around engaging seldom heard voices. And we know that public health messages that can improve patient outcomes don't always reach those who they could benefit the most. Today, our panel will share best practice examples that demonstrate the benefits of going beyond traditional channels to help all patients access better health information and ultimately to have better health outcomes. I'm pleased to introduce our panel. Firstly, Maya Anoka, who is Head of Communications and Marketing at the Patients Association. She's worked in healthcare comms for more than 20 years, and until her recent appointment at the Patients Association, she was part of the Vaccines Task Force communications team that played such a pivotal role in the UK's response to the COVID pandemic. We're also delighted to be joined by Emily Bone, who is Patient Engagement Excellence Lead at Janssen. She's more than 20 years experience in health-related comms campaigns, and she's been with the pharmaceutical company Janssen for nearly a decade, holding roles in both UK and above country teams. Unfortunately, Claire Hankey was due to join us, but she's unwell. So we have Claire Reeve, Head of Communications and Engagement at Mid and South Health and Care Partnerships, alongside Kat Raven, who is also Head of Communications and Engagement at this organisation. Thank you for stepping in, both. Claire's role prior to COVID-19 was Head of Comms and Engagement for 2 clinical commissioning groups in South East Essex, and Kat has worked in PR for more than 15 years, leading communications and engagement for national health charities and NHS organisations. And finally, we have Ed Harding, who is Managing Director of the Health Policy Network. Ed co-founded the Health Policy Partnership in 2015. In recent years, he's led on HPP projects in cardiovascular health, including acting as the Network Director for the Heart Failure Policy Network since 2015. And this is a multidisciplinary and Europe-wide collaboration of senior stakeholders. So now we're introduced, each panellist will share with you a short piece about their experience and examples of working within this area. If you have questions, please pop them into the Q&A box, and this will be picked up in our question and answer session after all panellists have presented. So without further ado then, I'll hand over to Maya, who will take us forward.
Thank you very much, Sarah, and hello everybody. So my name's Maya Anoka. I'm Head of Communications and Marketing at the Patients Association. I joined from the Vaccines Task Force, but before that I had a long career in pharmaceutical healthcare communications, where in fact Emily was one of my clients a number of years ago. So I have a breadth of experience when it comes to communications, and what I would say is, now that I am very firmly on the patient side, I would change the phraseology from hard to reach communities or seldom heard from communities to actually hard to reach health services, because from where I sit now, that's what I see. I see that patients try to get in touch with health services, but there are barriers in their way because health services are extremely inflexible in how they want to see patients and make provision for patients who have learning disabilities or English as a second language. And so that is a real issue. And communications professionals within health services and health providers, health and care providers, can make an enormous difference to patients' experience of healthcare. And one of the questions that I was asked to consider was, what is the pivotal role that communication plays in ensuring patients understand their illnesses and treatments available to them? And one of our recommendations as an organisation is patient partnership. And shared decision making, patient engagement, and all of those things that bring patients and their healthcare providers together in a discussion about what is optimal for that particular patient in their particular circumstances, which will not be the same for every patient with the same condition, because they will have different personal circumstances that drive their particular health goals. And it's important that doctors, nurses, physios, pharmacists all understand that, and that communications supports this individualised, personalised care approach, which we talk about a lot, and the health service talks about a lot, but it doesn't always happen. And so we need to think about how do we make that happen, because one of the things about kind of inflexible systems that we have learned about recently, so last year we set up a lived experience advisory board that has actually been working with us so that we understand more about the challenges that are faced by seldom heard from groups. And one of the things that they have made very clear to us is that some of the ways in which the health service gets in touch with them is just not suitable. So letters, appointments, being told that you're going to be phoned at such and such time and not being phoned, or actually finding phone calls very, very difficult, being expected to go online, multiple communications from different parts of the system that aren't aligned. This all is incredibly inefficient for the health service, it's very confusing for the patient, and just leads to this rotating door of patients coming back into the system because lack of communication has sent them to the hospital at the wrong time, or it's resulted in wrong treatment. So it's very, very difficult from that point of view. So just to conclude on that, patient partnership, shared decision making, involve the patient in any decisions about treatment or treatment options. And it is actually been one of our recent recommendations that shared decision making is actually taught during medical training, so that it's more natural for doctors to adopt that approach when treating patients. Barriers to good practice. I think it depends on whose communications you're talking about. I think often, say, professionals within the system are very, very good, but often it is the people around you, say, in pharmaceutical comms, compliance colleagues who don't necessarily understand that you can say, we're holding a group is just as correct as we're convening a group, but holding is something that perhaps is more casual, more conversational. And I think the same probably goes for communications professionals within the health service and within other organisations, about our goal of having clear, conversational, accessible communications being undermined by other people who have a say in what our output is. And I think definitely as comms professionals, we should be standing up for plain English, accessible, friendly English, especially when you want somebody to do something. And I think that's very, very important. In terms of, say, delivery of health and social care services, time is often a barrier. Not enough time to explain things, not enough time to sit with people and learn about what it is that they want, which goes back to the point about the shared decision making. I think also there's always the issue that there's perhaps too much jargon, too much text for people to wade through, all the caveats around options and risk benefit. And we had a talk from one of the professors at the Winton Centre on Risk Management, Spiegelhalter's place, and she was saying that it's very, very interesting looking at the difference in patients' and clinicians' attitudes to how to communicate risk. And that was of great interest to the people at our meeting. So, for example, a 1 in 100 risk, a clinician thinks that's fine, but the patient just thinks, oh, I am that 1 in 100. So how do you deal with that? So that you need to have some understanding about how you communicate with patients in terms of making risk and benefit understandable and not terrifying. And I think that is a work in progress for all of us. The other thing that I was asked to comment on was 1 or 2 examples of great practice in communications activities. I'm not sure I have any, if I'm absolutely truthful. So at the Vaccines Task Force, a lot of the communication we had was around results of incredibly, unexpectedly successful vaccine trials, and they really didn't need any communicating on their own. I think the government's communications around the pandemic and the safety precautions that were put in place to protect us all and the NHS were good to begin with, and then rapidly went off the boil and became very muddled and confused. And I think we now see some very garbled messaging around the current status of the pandemic, with former health ministers saying we've exited the pandemic, which I think is probably news to most of the doctors treating COVID patients in hospital at the moment. But conclusions and top tips for communicating with groups that you perhaps would like to talk to more and don't have good access to is to be accessible, to let groups that you would like to have a dialogue with know that you would like to be working with them, be talking with them, be supporting them, be open to partnerships, be humble as you approach them, make sure that they don't think you just want something out of them, but that you actually have something to offer those groups. Be patient as well. If you're dealing with groups from organisations or communities that have not normally engaged with health service or with the pharmaceutical industry, they will be cautious, they will be on their guard, and you will have to earn their trust in order to be able to work with them, provide them with information. Practice shared decision making in everything you do. I mean, it's not just for the doctors and the nurses and the other physicians to do that. I think it's for all of us seeking to work in communications with groups like that. Don't present finalised plans to them. Bring them on board early and make your plans together. That's it.
Thanks, Maya. I think the point that you're saying around earning trust is one which I think strikes across everything that to do with engaging anybody. You have to earn that trust. That's really nice. Thank you. And I'm going to bring Emily now into the conversation. Emily, over to you.
Thank you very much. Right, okay, so I'm Emily Bone and I'm part of the Above Country team at Janssen's Europe, Middle East and Africa commercial organisation responsible for our patient engagement strategy. So as an organisation, we're committed to improving the lives of the patients that we serve, which we do in a number of ways, but primarily through our collaborations with patient organisations. So these collaborations with patient organisations, we do either to develop initiatives to support or empower or educate patients and indeed their families and caregivers. And this is about managing their condition and or overcoming some of the challenges that they may face living with it. And we also collaborate with patient organisations to bring insights and understanding patient needs so we can bring them into the organisation and ensure that everything we develop which touches patients really reflects their needs. So I'm kind of bringing, I want to share with you today a very specific case study about a project that I was responsible for a couple of years ago, which is still running today, which is all about communicating and educating a broad spectrum of patients about how to manage a challenging disease. And so I will be sharing some slides with you. If I can just work out how to seamlessly go into presentation mode. So hopefully you can all see this. Cool. It's not gone into presentation mode. Good. Okay, so as I say, this is a case study which is about a particular the disease area of inflammatory bowel disease. So we know that people newly diagnosed with a condition can really benefit from telling and hearing about the stories of others. And as you know, the internet is absolutely full of helpful, mostly helpful videos and blogs from people who are willing to share their experiences on social media or indeed many of the other platforms available. But what about those conditions where people don't want to go public about their disease? Because I'm sure, as you all appreciate, certain conditions can carry a kind of perceived stigma. And people who suffer from them don't really want other people knowing they have it, and are somewhat unwilling to go public about it. And I think this was the situation we found ourselves in a couple of years ago when we were looking to create a patient education campaign for people who are newly diagnosed with inflammatory bowel disease, or IBD as it's generally known. And preliminary research that we'd done suggested that people with IBD felt there was a real lack of information about the disease, and what little information there was tended to be quite negative and quite depressing. Now, interestingly, this wasn't really the case in the UK, where I think perhaps people are less inhibited about kind of sharing or talking about sort of so-called embarrassing conditions, but certainly this was very much the case within some of the other countries in the Europe, Middle East and Africa, the EMEA region. So just in case any of you on the call aren't that familiar with this disease, here's a quick IBD 101, just to provide you with a bit of context. So IBD is essentially two main diseases, Crohn's disease and ulcerative colitis. It's characterized by chronic inflammation of the GI tract. Symptoms include, as you can see from these nice images here, abdominal pain, bloating, prolonged bouts of diarrhea, which can be bloody, weight loss and fatigue. And I think given the detrimental impact on people's lives, it can lead to psychological issues such as depression, anxiety, and a feeling of isolation. And it's a very unpredictable disease. So accidents can happen if you don't get to the loo in time. There's over 3 million people in Europe who are affected, and the kind of peak age for diagnosis is between 10 and 40, but really it can occur at any age. And so we're talking about a huge spectrum of patients who are potentially affected. So I guess going back to my story, when I met the excellent team at the European Federation of Crohn's and Colitis Associations, who are generally known as EFCA, they were and we explained to them that we felt that we kind of could play a role in sort of making information about this disease more accessible. They kind of suggested to us that actually we might struggle to find people willing to take part due to this kind of sort of slight reluctance to go public about their experience of having this disease. So we kind of tossed some ideas around about how we might get around this issue. We thought about maybe using actors to voice kind of real patient experiences, but we kind of discarded this, so it would be too expensive and too time consuming. And plus we wanted this video series to really resonate with patients across a wide geographical area. So one bright spark, who sadly was not me, suggested using animated characters to tell people's stories. Because, you know, which has actually turned out to be a very good idea, because, you know, what's great about using animated characters is that you can channel many different people's experiences through a relatively small number of characters. And as I said, in order for these animations to resonate with a broad audience, we created 3 characters to represent 3 life stages. So we have, as you can see in front of you, we have a student, a young mother, and an older working man. And this enabled us to create storylines which covered common situations and sort of life milestones appropriate to the age and stage of these age groups. So over the period of 5 years, I worked with EFCA to create 5 different animations covering topics recommended by EFCA's Patient Advisory Network. And, you know, and I think the really great thing about co-creating this initiative with the patient networks was that the storylines really reflected actual patient experiences. So every situation, every piece of advice, every theme within the animations came from people who had actual experience of living with this condition. And the other great thing about using this medium is that you can pack an awful lot of information in a relatively short space of time. And as I say, this type of animation seems to work very well across geographies. We're also very lucky to find a great video production company as well. They're called Laquona, who created this, and you probably can't see it from the image that you can see, but this kind of clever pop-up style, pop-up book style animation, which worked really well. So was it successful? In relation to uptake, absolutely it was, yes. To date, some or all of the 5 videos have been adapted by more than 20 countries, probably 25, and it's available in about 30 different languages. And here are my thoughts as to what was behind the success. So I think certainly from the feedback we've had is that the series meets a significant information gap for people with IBD. The videos are short, they're easy to watch, and they provide positive, practical and upbeat information about how to live well with IBD. As the content was shaped by patients, people watching them can really identify with the situations that they cover. So EFCA was as invested in this project as we were at Janssen, and actively promoted this initiative through their own kind of patient organisation network. And obviously this was supported with the rollout through Janssen's, through our own affiliate network as well. And I think importantly, the videos are relatively easy to adapt, and as I say, work well, and are sort of easy to adapt and share across countries. And I think also this medium works really well on social media. And certainly the kind of campaigns that I ran in my role, and obviously the ones that my colleagues did at a country level, got really good engagement. And so I guess finally, what do we learn from this? For me, it was the kind of the value of good relationships built on trust. You know, this initiative would not have been as successful as it was without building the strong relationships that we did with EFCA. Because I think as a pharma company, you have to work really hard to build trust with patient organisations, but it's worth the effort, because if you get it right, you can really make some magic happen. And obviously there's not time on this today to just sort of screen any of the animations, but if anyone's interested, you can find them either on EFCA's website or on Janssen's janssenwithme.com site as well. Thank you very much.
Thanks so much, Emily. And I know that there's a question in the chat that Kat will be picking up at the end. But interesting again to hear about trust. It's definitely an emerging theme across all. So I'll be interested, Kat, to hear what you have to say, as well as Claire. Thank you.
Thanks very much, Sarah. So yeah, just to explain, Claire Hankey, our director, sadly is poorly today. So Claire and I are standing in, doing a bit of a double act today. So just to explain, so we're from the NHS, we're from a health and care partnership in Mid and South Essex. And essentially what that means is that we are the comms team that supports all of the different providers across our patch, and that includes a real variety of different organisations. So currently we're employed by the clinical commissioning groups, and there's 5 across our area, but also there's a hospital group which includes 3 hospital sites which are acute sites across Mid and South Essex. We also have community providers, 3 community providers, as well as over 150 GPs, and we're just spread across 200 sites. So it really is a wide variety of sort of about 45,000 healthcare professionals that we as a comms team need to engage with and work with to make sure we are really engaging with those seldom asked groups across our population. So a real challenge, but really very much at that sort of local, regional level. So that's sort of the example we're bringing today, but just gives you a bit of a flavour of the different types of partners we work with. And you can see on the screen sort of some of the different providers that includes. But really to be able to meet that challenge of really improving the lives of people in Mid and South Essex, and that really is our strapline, is working together for better lives. Actually, health and well-being can't really just be addressed by engaging with people about their health. It's just so much bigger than that. So for us, it is really important we work with lots of different providers across both the public and private sector. So whether that's councils, that's social care teams, that's private providers, to really making sure we're getting to the heart of the things that really make a difference to people and those wider determinants of health. So you can see on the screen, we talk about things like built environment, different socioeconomic factors, so things like income, employment, housing, are really key to engaging with our population to make sure they have access to the best possible opportunities, which obviously links to their health needs. And then the next slide. Claire's very kindly managing that for me. As you can see, and I'm sure this is very familiar to those people that are online today, obviously we have a real kind of complex number of audiences that we have to deal with on a daily basis to really make sure that they are getting the messages they need. But obviously we're listening to those groups and really hearing what they have to say. So just to pick out a few, obviously kind of our residents are really key to that, and making sure that we're engaging them in different ways. So from really kind of targeted ways that we engage those groups, right through to our employers. As I mentioned, we've got 45,000 staff across our area that ultimately are residents as well. So really making sure that we're engaging with these different audiences and really tailoring our approach depending on how we need to engage with them. So one of the things that I'm going to hand over to my colleague Claire Ralph now is to talk about how, as a comms team in the last 2 years during the pandemic, we really changed the way we were working. We were 5 separate comms teams from the clinical commissioning groups, and literally overnight came together to work as one kind of big fantastic comms team. So I'm going to hand over to Claire now just to talk about the ways that we did that, and some of the ways we really have changed the way we work to engage these seldom asked groups, particularly in the vaccination programme. So over to you, Claire.
Thanks, Kat. Firstly, can you hear me okay before I carry on?
Yeah, loud and clear. Thanks.
Yeah, fab, good. So I have Wi-Fi issues today, so sorry if the sound isn't particularly good. So as per the slide, and thanks, Kat, she's already explained, along came COVID. So there is no question that living and working through the pandemic was incredibly challenging, the most challenging time, I'd say, for most people that are working across health and care. As the NHS declared a level 4 incident, we were obviously mandated to go into control and command functions. And that was for the comms team. We kind of were launched into a completely new world, as Kat alluded to, with system first thinking. So prior to COVID, we were all kind of geographically communications leaders. So I was leading the South East Essex patch around comms and engagement, and Kat in Mid Essex, for example. But all of a sudden, we were developing new system channels, protocols, lead roles. So my lead role was around engaging with colleagues in GP practices, constantly communicating the new guidance that came in on an almost hourly basis, new ways of working to keep everyone safe overnight, switching suddenly to a total triage model, talking about PPE, the types of PPE people could get, and obviously the impact on the wider services, impacting on referrals, etc. I remember joking to a colleague as we kind of left our offices back in May 2020 that we had just managed to go live with the first GP bulletin back then, and we said, "Oh, can you imagine when we were on 170?" I joked this morning because I'd literally just signed off 185th issue of our bulletin that now goes out weekly. But it wasn't all bad, because actually it was a huge opportunity to come together, one as a community, a communications team, sorry, but also with our wider colleagues across health and social care. So just go on to the next slide. So COVID, even though obviously I've mentioned the obvious challenges and awfulness of COVID, it really helped to provide that shared purpose to build relationships. Obviously, colleagues on the call have already talked about the fundamental importance of trust and relationships. It is everything when it comes to collaborative working, and knowing that some of the most unengaged groups were also the very same groups that were proportionately impacted by COVID was really key. We could reach out to those that would have the most influence over those groups, and to be our messengers, working together, making sure that obviously we've got the best possible chance to use collective resources to do things together, to innovate together, and co-design, more importantly, to maximise the benefit for the people we're all serving. So obviously our role was to make sure we had the consistent narrative going out, but obviously working with our partners, and as it says on the slide, in the local authority, but really importantly in the voluntary and the community sector, was making sure that those messages were delivered in the right way by the right people. It's the basics. It's making sure, it's delivered in the right format, be that easy read or even, in the right language. So, and then along came the vaccination programme. So a core strategic aim of our integrated care systems and integrated care systems in general is about reducing health inequalities across our population. We have to recognise that one size doesn't necessarily suit all. And when it came to the COVID vaccination programme, data was showing us, real-time data, the uptake and where we need to focus our efforts. And also, it was also showing us, who were more at risk of ill health than others. We know that for some people, there are clear barriers to accessing services in general. So Maya obviously touched on that earlier. And there's a variety of reasons why that is. So we would be absolutely kidding ourselves if we thought that we could do this alone. So the COVID vaccination engagement programme and communications programme, was absolutely with trusted community leaders, and making sure that we were really working closely with the people that had those relationships, really get underneath what those barriers were, what their preferences were, and any opportunities that we could realise to remove those stigmas and barriers. It could even be a language barrier, but equally there was lots of people in our population that weren't even registered with a GP practice. There were certain communities that had a preference for single-sex clinics, and wanted just more private space and the time to ask questions in what was a very mass vaccination effort in the first instance. So just to allay fears, or purely just to deliver, get a jab in a time that was the most convenient, given that there was people still working really hard 24 hours a day, particularly the key workers, and making sure that our vaccination programme was as accessible as possible was really important. So as Maya mentioned before, a real personalised approach. So on the slide is some examples of how we did that. So we set up very quickly an Essex COVID vaccine website that was kind of like our go-to one-stop shop with information about all of the clinics that were available. Now, nationally, obviously, there was the National Booking Service that had the mass vaccination clinics, but due to the complexities of the programme, there was pop-up clinics coming on stream all of the time. So making sure people had all of the information about all of the clinics and those that they could just walk into to support, you know, the convenience aspect was really important. A big part of this was co-designed outreach solutions. So a big project that we were involved with was the delivery of a bespoke vaccination vehicle that we did in partnership. We were very lucky to maximise our relationship with a local massive international car manufacturer, Ford, who wanted to help. So at no cost to us, they helped to deliver this mobile clinic effectively. And we then linked up with our community leaders, with our engagement specialists to work with community leaders where we knew the uptake was low to co-design those solutions. So I mentioned there about single-sex clinics, and in that picture actually is the Chelmsford Essex Muslim Society, where we launched our bespoke vaccination clinic and offered single-sex vaccination. So I think the men came into the van and then the women were in a clinic inside. That little sign there was showing which way people needed to go. But also we took it to, you know, the traveller groups, we took it to Tilbury Docks, to lots of different places, to circus workers that, you know, they said they're out all of the time, they're too busy to be able to go to the mass vaccinations, or they don't want to, because a lot of groups actually, there's a lot of stigma involved in getting COVID vaccination, and they wanted a discreet way of getting protecting themselves. There was lots of other things that we did as well as the vaccine van, but fundamental was working in partnership with people in the community. And in terms of the success, I guess finally, it worked. So there's a couple of bullet points here, but we had the best uptake in the region for our diverse communities. And more importantly, those relationships that we have built during COVID have lived on. So a big part of the integrated care system moving forward is the relationships that our GP practices or that are now working in primary care networks have with those wider communities. And having delivered this bespoke vaccination vehicle or clinic in those communities via the local GPs, they're now starting to talk about other ways that they can support prevention agenda. So holding clinics to support hypertension, or, you know, respiratory is the latest thing that we're going out at the moment to offer spirometry testing to some of the same groups, because a lot of the groups that are harder to reach, unfortunately, there is a link with those groups that face health inequalities. So building those relationships and the trust with their local health service is really important. And then finally, I will shut up now because I feel quite passionate about this, is our contact for more information. Obviously, we're limited on time today, but I did say to Kat that I would share a link in the chat to a video that we recently showed as part of a nomination to the HSJ Partnership Awards that summarises the Essex Van initiative for anybody that's interested in watching it. I'll stop there.
Thanks so much, Claire and Kat. Really interesting to hear about those examples, and I'm hoping that people found that useful to hear real life application of some of this stuff. Excellent. Okay, Ed, I know we're very short on time, so I appreciate that we did say that we were finishing at 12:45, so hoping that a few people might be able to stay on just for a couple of minutes more so that we can close off with questions. But over to you.
Very much. So I'm going to present an example of a European campaign that's worked over several years. My name is Ed Harding. I'm part of the Health Policy Partnership. This is our longest running project in which a group defined by heart failure can be understood as a underserved group. And we acted to bring that group together and to seek to advance them in policy debate, i.e. government debate. Next slide. So if you haven't heard of heart failure, it's actually quite a common condition. It can be, most people, 1 in 5 of us at some point in their lives may live with it, but it can affect people in later life, also people at younger ages as well. But what you might not know is that it is one of the leading causes of hospital admissions and readmissions in England and also across the high-income world. So this is a syndrome that's really come from being widely misunderstood, very little therapeutic and management options, to a syndrome that can actually be managed really quite effectively in the case of very many patients. And a lot can be done to manage it, to keep people out of hospital, with obviously huge incentives to do that in the context of the pandemic, but also goals of sustainability, reduction of acute spend, and the simple importance of course, helping and supporting people who live with a condition. As you can see from some of the stats, we can get a really great deal of effort there. But why might it not be sort of heard of? Why might it not be very well served in terms of advocacy? As I said, fatalism, changing care guidelines, a relatively under-mobilized advocacy base in cardiovascular disease overall, all kinds of reasons that would feed into this. So we've got really quite a long way to go. And other sort of supporting factors would be that very few countries have an effective policy. So the government has a strategic position on heart failure, what to do about it, and is prepared to coordinate investment to produce it, which might surprise you given the burden and its relevance, but that's where we're at. So this project, in essence, has been a story of trying to bring heart failure through evidence and consensus, to empower advocates to represent to decision makers, to their governments, putting into their hands consensus, clear messaging that really has empowered them. I think we can show very clearly that in certain countries like Spain, Canada, we really helped advocates to do that, and they've managed to connect with decision makers and to win recognition from them to a degree as well in England and France and other countries too. So you can show a clear line between arming, as it were, advocates with these materials and also in creating a community and a place for them to go. So I think a key message from this is that it had to be multidisciplinary. It's not a patient advocacy campaign per se. It's actually a multidisciplinary campaign. It brings together clinicians, NGO leads, patient advocates, others into a clear societal argument and voice as a way of making it powerful and a way of connecting and cutting through. As you can see there, if you want to find out more about it, it's not hard to find. An essential message I think that we really have dealt with across this whole piece is that it's been seen as being difficult. Heart failure is difficult. Well, you've got acute heart failure, chronic heart failure, you've got heart failure, preserved ejection fraction, reduced ejection fraction, and so on and so on. I won't go into that, don't worry. But really what we did is clarify very simply. You can see here a key diagram from one of our reports that yes, there are different needs across the care pathway, but you can really clearly lay out, if you do this properly through consensus, through an evidence-driven approach, really lay out what a vision of what high quality care is, also what patients and society get from it. So we know our advocates have used these materials to connect and to communicate with decision makers. So very broadly, what this is about, I think, the art of the possible, using evidence and data to connect, building advocacy groups, just as colleagues were saying earlier, this understanding ourselves as an efficient central hub, producing these messages and materials, but ultimately that national and other advocates would pick them up and use them, reducing their barrier to entry. We have seen over this period heart failure transform very significantly. On the left, you have a spiral into death diagram from about 2014-15, clinically very accurate, but not a difficult one for people living with heart failure and for decision makers to understand. On our right, we've got some of this fantastic imaging from the British Society for Heart Failure and from Pumping Marvellous. So two fantastic UK organisations really completely changing the debate on heart failure towards vitality, hope and political constituency. You should really look at those two organisations. If you don't know of them, they're really, really quite something. So just a whistle-stop talk, but I'm happy to talk to anybody about the programme and really its approaches. But a key message, you've got to focus on solutions. You've got to understand and meet decision makers where they're at and make a pitch to society as to why your condition and population are key, but you can achieve quite a lot if you're willing to do that and be patient.
That's really helpful. Thank you, Ed. That's great.
Thanks so much, Ed. Sorry.
Over to you for Q&As.
Thanks, Sarah. Thank you, Ed, as well for going through that so quickly. So I think we've got two main questions that have come into the Q&A. So the first is, I'm just going to read it out. So one of our attendees, Jane Nellis, has said, I think the challenge is that groups who we class as traditionally unengaged have either previously tried to engage with health services, have had a poor experience, and have been actively excluded by the health system, and talks about different types of groups that includes LGBTQ plus people, disabled people. So what do the panel think health organisations and health communicators should do to rebuild broken trust with these historically excluded groups and to address deep-rooted health inequality? So perhaps, Ed, if I could come to you first, if that's okay.
Building trust with historically excluded groups. I guess from our perspective, it was the trust issue. So we're a multi-funded campaign. So it was very, very important that so we're funded by life science industry. It's absolutely critical that we're multi-funded. It's absolutely critical that we have clear terms of reference that give us independence and make us the chief editor. It's critical. So we have a steering committee representing patients and other key supporters, and they actually help us design the strategy and validate our program. So those sort of key aspects are really critical, but also time. You have to prove, you have to earn the right and demonstrate who you are the hard way, and then people do come around, I think, to realizing that that you share the agenda, that they will work with you, and that you're a reputable organization that they can work with. But patience and time.
Great, thanks, Ed. Maya, would you like to come in on that point as well?
Yes, happy to. I think the questioner is right. Some of these groups that we can consider hard to reach or seldom engaged with have tried and failed for whatever reason. And I think if you want to build a relationship with them, it's very much like Ed said, you have to show that you're trustworthy. You have to stick with it. You can't come with one offer, it fails, and then you go away and you never come back until you need them again. And I think how you do it depends on who you are, what sort of organisation you are, and what it is that you're hoping for. But I think all of these groups value a long-term, positive, bipartisan relationship, and that doesn't mean that you're working with them every day of the week, but it does mean that you're touching base with them, finding out how things are going, perhaps coming together more frequently for one particular project, but that you're not, as I said before, you're not coming to them when you just want something.
Yeah, absolutely, definitely. Emily, was anything you'd like to say on that as well?
Sure. I think, you've already mentioned trust. Obviously, that's really, really important. And I think, when you are able to engage with people, it's the really listening and understanding their needs. And I guess the only other point I would add is in terms of like co-creating solutions with them and really ensuring that their needs and concerns are reflected in whatever kind of comes out of it.
Thank you. I think it's sort of that the theme really today has been that trust, isn't it? I think that's the key word here, really, how you build those relationships and maintain them as well. I think, as you were saying, Maya, that's so important. You're not just going to them when perhaps we need something, that actually it's that ongoing relationship.
Well,
there was also another question I'm going to come.
But I just wanted to pick up the point. Your work in Essex is around vaccination shows that there is a lack of trust amongst certain groups. So it is a really, really important thing. And historically, certain groups don't trust health services, don't trust vaccinations in the same way that other groups do.
Yeah, absolutely. It's an ongoing kind of relationship, isn't it? I'm going to come to you now, Claire, if that's okay. So there's a question particularly about how we really sort of managed our budgets around the work we did locally. So talking about a split between production and resources, perhaps translating things into different languages as opposed to kind of more traditional media and how we manage that. So could I come to you to answer that question? Can you hear me, Claire? Can't hear you, Claire.
Is that any better?
Yes, go for it.
Sorry, I'd leant on a button. So yeah, I guess back to the question. So yeah, the split, it was important. So obviously with something like the vaccination program, that was a national program. So we had national core narrative that we had to cascade into our communities to ensure maximum reach. So yeah, splitting the budget to make sure it reached as many different people in different ways. Sorry, my cat's just come in and meowed at me. I'm just going to shut the door. Was important, but the language, the information, because it was a national program, had already been translated into different languages on our behalf. So we were very reliant and wanted to work very closely, and we did, with our community and voluntary sector partners. And one thing that worked really well was shifting that power and giving them the money. So we launched a community grants program, and we said to them, look, these are the core messages that we want to get out into these particular communities. How can you help us? And so they would help to inform what those mini communications plans would look like with those that were trusted in their communities. And so we shifted the power, acknowledging that we weren't the experts in all of these different communities, so that the messages were getting to the right people at the right time in the right way. So hopefully that answers it as best that I can.
Thanks very much, Claire. I'm very conscious of time, and thank you everyone for staying for another kind of 5 to 7 minutes. So I'm probably going to draw it to a close there. Thank our panelists very much for some really insightful presentations. Today's session has been recorded, so we'll share that afterwards, and with speakers' permission, we'll share slides as well. Just a few reminders. So if you're not already a CIPR member, we'd really encourage you to become a member and join the 10,000 members that are already members of the Chartered Institute of Public Relations. If you are a CIPR member, then you can log your CPD points. I believe today is the last day for this year's log, and if you registered through the CIPR website, actually it's allocated automatically to your CPD. You just have to put your reflections, so do encourage you to do that. And we've also got a fantastic event coming up on the 4th of May around essential skills for behavioural science. It's going to be with an expert speaker, Ruth Dale, and it's 1 to 2 p.m. on the 4th of May, so really encourage you to sign up to that when that goes live. We've also got some other events planned later in April, again around building relationships with stakeholders and influencing with integrity. So again, watch out for those and sign up to our newsletter if you haven't already. But thank you very much to everybody for joining today, and I wish you a good rest of the day. Thanks so much.
Thank you. Bye.